So it's very important for us to understand how the opportunistic infection behaves in the era of extensive use of antiretroviral therapy. So welcome all for this important discussion on opportunistic infection in children. Today I'm going to run through various aspect of opportunistic infection in children. So we are going to have a small introduction on pediatric OIs and common comorbidity among children living with HIV, and what are the factors which influences the spectrum of OI you see in our clinical practice, and syndromic approach to common OI. Usually they don't come to you with a label. They will not come and say that I'm having a PCP pneumonia or I'm having a tuberculosis. They will come with some symptom, maybe a fever, cough, cold, or something like that. So how do you approach them? How do you arrive at a diagnosis? That is called syndromic approach to common OI. As well as we'll also discuss in between prophylaxis, diagnosis, and management of such OIs. And we'll discuss some case scenarios, how to apply the syndromic approach, and national immunization schedule, because immunization plays a very important role in the prevention of OI, as well as in understanding how the OIs are presented in children. So with this objective, let's move forward. We all know that HIV-1 associated opportunistic infection encompasses a different various life-threatening infection, and it always hallmark immune suppression. If there is an opportunistic infection, it is equal to immunosuppression. So typically affects patient with low CD4 count. So as I already mentioned, before availability of this potent ART regimen extensively, these OIs were the primary cause of death in children with HIV. However, the current ARV regimen, which can effectively suppress the viral replication, will provide a significant immune reconstitution and resulting in a substantial decrease in HIV-related OIs and deaths, both in adult and children. However, the evaluation and management of the most commonly encountered opportunistic infection requires an interprofessional team. It's not a one-man's job. You need a multiple specialties to be involved so that you can effectively manage these infections, and outcome will also be good if you have a more specialties involved in the care. The common comorbidity of CLHAV, especially at the time of diagnosis, you can see a list of systems where you can see the comorbidity. But among these system, just a minute. Yeah. So you can see the opportunistic infection is the major cause for that. For example, in infection, okay, anyhow, we are talking about infection, it will be OIs. When you look at your gastrointestinal system, then again, you will have a recurrent or persistent diarrhea, candidiasis. So these are again infectious cause, whereas recurrent persistent oral ulcers is a non-infectious cause. Hepatobiliary, you have hepatitis B, C, and hepatitis due to other organisms. CNS, you have again tuberculosis, cryptococcosis, HIV itself, bacterial agents, and even in respiratory, you have pneumonias, even in otitis media. So all these are infection related. Skin and soft tissue will have infections. So OI plays a common, very important role in comorbidities which are associated with HIV infection, not only in children, even in adult also. So why the diagnosis of pediatric OI is important? As I already mentioned, OIs are coming down because of ART, but still it is important to diagnose them, because despite there is a universal upscaling of ART services, this prevention and treatment remains a critical component, because they continue to present as a presenting complaint in HIV, HIV among those children who are exposed to HIV, but their status are unknown. They are HIV exposed infant. So what is happening to the epidemiology nowadays is most of these children would have escaped our PPTCT intervention and they are infected. And majority of them are are long-term survivors. That means they are asymptomatic till significant number of years. So they manifest somewhere in the late first decade of life or early second decade of life. So during that time, there will be gradual decrease in the CD4 count. So they present you as a opportunistic infection because their CD4 is down. They will have a chronic effect of HIV infection resulting in malnutrition, some altered immune dysfunction. So all these things will present as an opportunity to develop these infections and present to you as a first symptom. So still you should not forget why even there is a universal ART services. And for infants and children with known HIV, various barriers may hinder effective HIV treatment. For example, there is an inadequate medical facility. Though the ART centers are available, but nowadays the HIV care is more or less restricted to those ART. But in the general population, in the general pediatric care, still HIV is a neglected one. So the medical care in the general pediatric services related to the HIV is still inadequate. So in that context, it's a barrier for the management of OI infection. Similarly, lack of availability of suppressive ARV regimen. Though we have a very good regimen now, there are some issues there. There are some challenges, especially in children, regarding acceptability of those regimen and sometimes supply chain issues, interruption in between. So there may be since we are using very extensively ARV drugs, there will be issues of drug resistance. So all these things can lead to a non-suppression of HIV, leading on to immune dysregulation and then opportunistic infection. And most important factor for the success of ART regimens are adherence. But we all know there is the adherence, there are challenges which are multifactorial. So these are the barriers which will also impede in provision, will come in the way of giving or providing prophylaxis for these infants and children. So we need to understand that there are barriers which are common for both HIV management as well as prophylaxis. So, and another issue here is when you give a prophylaxis, that will increase the pill burden and that will lead to suboptimal adherence. And more drugs, more interaction, the treatment efficacy may be decreased. And more drugs, there is an increased frequency of adverse event which may be overlapping. And we all know iris can complicate treatment of OIs, especially when ART is started early or when optimization of a failing regimen is attempted early before you treating an acute OI. So considering all these things, prevention and treatment of OI in children with HIV remains an important component even in the era of combined ART, availability of combined ART to everybody, universal. So then what is OI? Opportunistic infections are infections caused by a microbial agent in the presence of a compromised host immune system. So it needs an opportunity to infect a person. That's why it's called opportunistic infection. So it's not that simple. Whatever we are saying is not that simple. Though we are seeing some of the organisms, unusual organisms infecting these hosts, which are commonly not seen in an immunocompetent host. That's a classical, in classical sense, they are opportunistic infection. But sometimes a common infection in an immunocompetent host may have a self-limiting course and will not cause much an issue there. Whereas in these children with a suppressed immune function, the common infection can lead to a severe catastrophic consequences. For example, a common chicken pox, which is a self-limiting in most of the immunocompetent children, can lead to a severe hemorrhagic form of chicken pox in HIV children. Sometimes even may lead to death also. So a opportunistic severity is also part of your OI. Similarly, there are some infections where the duration may be prolonged because of the suppressed immunosuppression. So a prolonged duration can also be a part of your opportunistic infection spectrum. So an opportunistic infection in HIV children is not just limited to an unusual organism. It is also related to, it also includes unusual severity and unusual duration. And sometimes even the opportunistic malignancies, though it is a non-infectious condition, sometimes may be infectious, but most of the time it's a non-infectious condition. But these malignancies are not seen in an immunocompetent child. So these are seen again because of dysregulated immune system or a suppressed immune system. So when I say an opportunistic infection, it includes an infection with an unusual organism, infection with an unusual severity, infection with an unusual duration, as well as opportunistic malignancy. So all these things together is opportunistic infection when we are talking about OI in HIV infected person, maybe adult, even children, whatever it is. Now, what are the factors which will influence the spectrum of OI? Spectrum of OI is not same in every CLHAV. It all depends on the age of the child. When we are seeing what is the nutritional status, whether there is a malnutrition associated or not, and what is the epidemiology of the pathogen, what is the pathogen which is prevalent in your local area. For example, in the season of dengue, any fever child, you need to suspect dengue there rather than any rare opportunistic infection. Similarly, environmental exposure. What is this child is exposed in the family? If there is exposure to the tuberculosis in the family, that will be the common why in that particular situation. Similarly, what is the immunological status? What is CD4? Vaccination received. Okay, drug prophylaxis, CPT prophylaxis, IPT prophylaxis, previous or a coexisting OI. Is this iris I am looking at? Most important is ERT. When did the ERT initiated? Whether the child is responding to the ERT or child is showing signs of failure to the ERT. How is the adherence? What is the duration of ERT? So all these factors will influence the spectrum of OI we are going to see in our clinical practice. There are some challenges in pediatric OI. The challenges are like, usually in CLHAV, the common childhood infections which we see in immunocompetent children like pneumonia and diarrhea, they are the commonest even in CLHAV also. But these common infections can be, as I said, can be maybe more severe, prolonged, or recurrent. Okay. And atypical clinical presentation may also be seen. We all know herpes zoster. Herpes zoster was never heard in pediatric age group before the HIV. So HIV is the one condition which will predispose these children for herpes zoster. It's an atypical clinical presentation. So challenges in early diagnosis and treatment again. So etiology to be considered in the view of immune status of the patient, which again depends on your ERT, CD4 count, bar viral load, immunization received, and prophylaxis which a child is receiving. So as I said, when we see a child with OI, you have to first do a situational analysis. That is timing and spectrum. What is the situation we are seeing? When are we seeing what? At what spectrum? At the what natural history of HIV we are seeing this child? Are we seeing this child at the time of diagnosis or in the pre-ERT time before initiation of ERT? Your spectrum will differ. Are we seeing this child within 6 months of starting ERT? So it may be an iris. Are we seeing this child with these symptoms when this child is having a stable HIV disease? CD4 is good, viral load is completely suppressed, nutrition is well maintained, recovered, and the child is on therapy for more than 6 months. So these are breakthrough infections. Similarly, are we seeing this child when the ART is failing? Then your spectrum will differ. Similarly, this child had a previous recurrent infections and leading to a sequel like bronchiectasis. In that context, what are the opportunistic infection you are seeing? So that spectrum will differ. So you have to do a situational analysis in each and every case, and then you have to consider when you're diagnosing, when you're arriving at a diagnosis, you should do a situation analysis and arrive at a diagnosis. So as I said, all these children will not come with a label of their OIs. They will come with symptoms. So with the symptom and the symptom complex, you need to approach them and make a diagnosis. This is called syndromic approach. So for the sake of this discussion, we have divided the whole this syndromic approach into 4 clinical syndromes. Number 1 is febrile syndrome, pulmonary syndrome, neurological syndrome, and GI syndrome. So for example, febrile syndrome. What do you mean by a febrile syndrome? Any child who comes to you with fever, only fever, nothing else. This is called febrile syndrome. So the causes are often similar to that in HIV uninfected children, but the presentation may be atypical and course may be prolonged. So it requires a prompt diagnosis and intervention. So the first step is you can divide the fever, can be an acute fever, acute febrile illness, where the history of fever is less than 7 days, or a prolonged fever that is more than 7 days, or fever with a focus. There is a focus. It's already a localized to a particular system, or it is just a fever. There is no focus. That is fever without focus. And the cornerstone in the management of febrile syndrome is clinical examination. Okay. The most common organism or general culprit, what we see in our regular pediatric practice: strep pneumoniae, H. influenzae, Staph aureus, Salmonella, other gram-negative bacilli. These are just community acquired, any of these things. But with the immunization against pneumococcus and H. influenza, the whole spectrum is changing now. Even, I mean, in the private sector, there is a typhoid vaccines are also available. So then we are looking at paratyphy there. Okay. So any child who has come with fever, you plus look at whether it's an acute fever or a chronic fever, I mean, prolonged fever, duration, and what is the local epidemiology. So suppose if this is a season of dengue or season of malaria, season of rickettsia, so your local epidemiology will direct you towards your diagnosis. Other factors like, is this child malnourished, or there is a history of contact in the family, immunosuppression, what is CD4? Sometimes CD4, though it will be low, that will be compounded with a bone marrow failure. There may be pancytopenia, febrile neutropenia. This bone marrow failure could be drug related, could be HIV related. We don't know what is that. We have seen zidovudine induced bone marrow treatment failure. You need to consider CD4 may be still good, but your bone marrow may be failing. Your neutrophils are low. You need to consider that. What is the recent viral load? Well suppressed. Okay. And what is the treatment status? HIV, ART initiated within 6 months, stable disease, or the failing regimen. What is the response to the ART? So consider all these factors to arrive at a diagnosis. The first step is always in children, assess for the danger signs. What are the danger signs? Ask for whether child can able to drink or breastfeed, child is vomiting everything out, or child is convulsing. When you ask these symptoms, then look for child's sensorium, whether child is lethargic or unconscious or irritable, and the child is convulsing now. If any of these things are there, this needs an urgent attention. There is no delay. You have to immediately refer to the pediatric department. The second step is, as I said, duration of fever, epidemiology, search for the focus, respiratory, GI focus, CNS, ear discharge, any rash, any urinary symptom. So look for the focus. So does the child have a painful skin lesions or a painful joint swelling? So skin infection, cellulitis, septic arthritis, any pain in the abdomen or a vomiting, diarrhea, yellow, jaundice or something like that. So intestinal obstruction, interception in a young child, dysentery. So fever, anemia, breathlessness, swelling of both feet, which can be due to your anemia, can be due to cardiogenic failure due to myocarditis, or it can be due to your kwashiorkor. So all these things you need to consider. AZT-induced anemias, infections, sometimes nutritional anemia like B12 deficiencies, iron deficiencies can also have these type of situations. So what is the child's latest absolute CD4 count and CD4 percentage? Both are important. And what is the latest viral load? What medication is the child currently taking, and since when this child is taking, especially cotrimoxazole prophylaxis. Regular long-term cotrimoxazole prophylaxis makes some of the diagnosis less likely, like PCP pneumonias. And what is the adherence? While the adherent to ART immunity will improve, iris may develop, which may present as a febrile illness. So adherence is very important to arrive at a diagnosis. And in case of prolonged fever, the common causes could be your tuberculosis, salmonella infections, sometimes occult bacterial infections, drug fevers. Rarely it can be malignancy, even MAC in a severely immunosuppressed child. So general physical examination, just do a complete surveillance from head to toe. Look at the general appearance, vitals, what is heart rate, what is respiratory rate, blood pressure, temperature, capillary filling time. What is anthropometry? Is this child malnourished? Is it kwashiorkor, marasmus? Whether child is having respiratory distress. This I am going to cover in the next section. And general physical examination, including skin. Is there any pustule, any cellulitis? What is joints? Is there any arthritis? Cardiovascular, abdominal, genitourinary, oral, any oral thrush, eye examination, ENT examination. So just do a complete survey from head to toe to find out any focus of infection. So any fever, this is a common guidance for you in the periphery, in the ART center. If you see a child with fever, look whether child is sick looking or any danger signs are present. If it is there, urgent referral. No, then look for localizing sign. The child is having pneumonia, child is having meningitis, here discharge, please refer. No localizing sign. If the age of the child is more than 3 months and a very mild fever, 100.5, then you can still try oral antipyretics, oral fluids. The child otherwise doing fine, no danger signs. You can explain the danger signs. You can ask them to come back after 24 to 48 hours to have a relook. Suppose if the child is less than 3 months, no risk taking, or temperature is more than 100.5, urgent referral to the pediatrician. This is a working flow, workflow for referral system for anybody who is working in a peripheral units. Management, start initially with empirical antibiotics and change to appropriate antibiotic based on the culture and sensitivity when available. Or symptom directed or any other diagnosis you make. For example, dengue fever, managed based on that, triage and other fluid therapy, oral or IV, depending on the triage. So it all depends on the diagnosis. But this is a general management of bacterial infection in children with a febrile syndrome. The second component of this discussion is pulmonary syndrome. What is pulmonary syndrome? Any child who present to you with cough and fast breathing. It may be associated with fever or cyanosis. Okay. This symptom complex is called as pulmonary syndrome. It may be just cough and fast breathing, with or without fever, with or without cyanosis. Okay. What do you mean by fast breathing? Any child less than 2 months, if respiratory rate is more than 60 per minute, age between 2 to 12 months, respiratory rate more than 50 per minute, age between 1 to 5 years, respiratory rate more than 40 minutes is fast breathing. This you need to remember, very important. This will be useful in every aspect of management of a sick child or a child with any symptom. So the infections which are common in with pulmonary syndrome are bacterial pneumonia, PCP pneumonia, tuberculosis, and some of viral agents like CME and other childhood viruses, like now we have RSVs, H1N1, all those things. Infiltrative disorders like lip, sequelae of previous telltale like your bronchiectasis, pulmonary hypertension, rarely fungal, non-specific interstitial pneumonias, and some sarcomas. So the approach will depend on the age of the child, whether it is an acute, subacute, or a recurrent onset, associated symptom like fever, clubbing, and cyanosis. What is the treatment status, especially ERT, nutritional status, immune status, and other OIs. So here we have a child who is a 12-month-old with HIV infection, brought with fever, cough, hurried breathing of 4 days duration, and feeding poorly for 1 day. On examination, child is lethargic, weight is 6.5 kg, height is 68 centimeter. There is generalized lymphadenopathy, oral candidiasis, hepatosplenomegaly, and respiratory rate is 66 per minute. There is chest indrawing, air entry is equal, no adventitious sound. SpO2 by pulse oximeter is 82% in room air. So how do you approach by looking at our whatever the management we have, protocol we have seen now? So first check for the general danger signs. So this child is lethargic. So this child is having a general danger sign. So this child needs to be urgent attention. And the next is anyhow this child is having a cough. How long this child is having cough? It's a very acute cough, just only 4 days. And we have counted the breath. This child is having 66 per minute and age is 12 months. So any child who is between 2 to 12 months, if the respiratory rate is more than 50 per minute, is fast breathing. Okay. And this child is having cough and difficulty in breathing. Child is also having chest indrawing. So any child who is having general danger signs, chest indrawing, fast breathing is considered as severe pneumonia or very severe disease. So this is how you classify. Only fast breathing, no general danger signs, no chest indrawing, it is pneumonia. No fast breathing, no indrawing, no danger signs, then it is no pneumonia, just cough and cold. Okay. So based on this, you can diagnose these patients. So this child is having severe pneumonia or a very severe disease. So most common in this age group is PCP pneumonia. Most common OI in infant with high mortality rate of 35% is pneumocystic girovascular pneumonia. The incidence is highest during the first year of life, usually peaks between 3 to 6 months of age, and typically they present with fever, fast breathing, respiratory distress, and cough. On examination, most of the time you will have a silent chest, nothing in the chest, but they will have distress and hypoxia. But in an older child, you can see an insidious in onset of cough and dyspnea, often present with a clubbing also. So chest X-ray will show infiltrate perihylar in the initial stages, progressing peripherally, and later they may develop a ground glass appearance. And this is how the PCP pneumonia. The treatment is oxygen, cotrimoxazole. The dosage, remember, 20 milligram per kg per day in 4 divided doses for 3 weeks. If 4 divided doses is difficult, you can make it even 2 divided doses also. If there is a hypoxia, that is partial pressure of oxygen is less than 70, then you may add steroid, short course of steroid, 5 days, 2 milligram per kg body weight. Then you can taper up over another 10 days or 21 days total. So total duration of therapy is 21 days. Remember, all children who had PCP pneumonia to be started on cotrimoxazole prophylaxis. That is called secondary prophylaxis. So cotrimoxazole prophylactic therapy, primary and secondary. Secondary, I said, primary prophylaxis therapy is in all HIV exposed infants or children. You have to start cotrimoxazole prophylaxis from the age of 6 weeks. If they are early infant diagnosis negative, you continue CPT till HIV infection has been reliably excluded by a negative antibody test at 18 months. If they are EID positive, you are going to continue their CPT till 5 years of age, regardless of WHO staging and CD4 count. After 5 years, or any child who is diagnosed after 5 years of age, look at their CD4 count, look at their clinical staging. If CD4 count is less than 350 or clinical stage is 3 or 4, you continue CPT prophylaxis till such time when your CD4 is more than 350 on 2 occasions and your clinical staging is come down to stage 1 or 2. So this is your cotrimoxazole prophylaxis in a nutshell. In the second case where a 8-year-old male HIV positive child presented with high grade fever, cough, vomiting, chest pain, and poor appetite of 4 days duration. So this is an acute fever, acute pulmonary syndrome. No past medical history. The both parents are living apparently well. They are HIV positive. They are doing fine. Birth and developmental history is normal. Immunization is up to date. 8-year-old child, remember. So this child is febrile, good nutrition. There is extensive crepitation over the right infrascapular and suprascapular and axillary area. Chest X-ray shows there is a patch. Okay. So a very well circumscribed homogeneous opacity involving right apex. So this is a pneumonic consolidation or a lobar pneumonia. Usually the lobar pneumonias are seen in an older child like this. In a younger child, you don't see lobar pneumonias. So children, especially CLHAVs, are at increased risk of developing pneumonias. Evaluation and management of pneumonia and CLHAV is similar to that in any non-infected, non-HIV infected children. So bacterial pneumonia usually respond to antibiotic within 3 to 5 days. Sometimes it may take few more days. A delayed response beyond 5 to 7 days would favor the alternate diagnosis like PCP, tuberculosis, unusual organism, viral or fungal, lip or a bronchiectasis. So here we have a 2-year, 9-month-old boy, HIV positive, initially asymptomatic. Father developed sputum positive pulmonary TB 4 months ago. He is on treatment. Developed cough, low-grade fever from last 3 weeks. Body weight of 9 kgs. CD4 count is 14%, 256. Hemoglobin is 8.8. CBNAT is MTB positive and rifampicin sensitive. How do you manage? What ART treatment you are going to start in this child? So anti-tubercular management includes, you have to give 2 drugs, 2 months of these drugs in the intensive phase HRZD and 4 months of consolidation phase. This is available in your RNTCP program. And then ERT to be initiated in these children as soon as you are stabilizing the tuberculosis, usually by around 2 weeks. So the regimen will be abacavir, lamivudine and DTG, and you have to modify the regimen by giving an additional dose of DTG in the morning. So you will have to give double dose of DTG in this child. And if this child is already having a CD4 of less than 350 and age is also less than 5 years, you have to give cotrimoxazole prophylaxis as per the weight band. So the pediatric TB, remember, is always, most of the time, it's a direct consequence of the adult TB. So usually it is transmitted from an adult tuberculosis patient. So you should always search for a adult TB patients in the family whenever you are seeing a pediatric TB. Infection with HIV is a strong risk factor for the progression from a latent to the active tuberculosis. But whereas in children, it may be a just progression of primary infection itself. Childhood TB with concurrent severe malnutrition and HIV infection contribute to a significant mortality and morbidity. And this co-infection occur in up to 50% of the children, and HIV disease many a times can present with an atypical features. So extrapulmonary TB and miliary TB are common, and you can also have like CNS TB, lymph node TB, bone TB, and other TBs in these children. Now, intensive case finding in children, any child who is more than 12 months of age living with HIV, ask for cough, fever, poor weight gain, history of contact with TB. So we don't have night sweat and other things here. So these are the 4 S symptoms we are going to see: cough, fever, poor weight gain, contact history with TB. If any of these things are there, then investigate for tuberculosis. If there is TB, treat TB. If there is no TB, consider IPT if there are no other contraindication. Other diagnosis, again consider ITP after the appropriate treatment. If for a screen negative, then look for any contraindication for IPT. If there are no IPT contraindication, give IPT. If there are contraindication like hepatitis or anything like that, you defer TB here. So screen for TB at each visit. Dose of IPT is 10 milligram per kg per day for 6 months. So CBNAT result, we all know how to interpret that. If there is MTB detected, not detected, look for other differential diagnosis. If MTB is detected and rifampicin sensitive, if it is new TB, initiate ATT. Previously treated TB, initiate ATT, but send for line probe assay and initiate ATT. If MTB detected rifampicin resistant, new patient referred to drug resistant TB center or previously treated, then confirmed by repeat CBNAT. And if sensitive RIF again, you can start ATT, but anyhow, you have to send for LPR liquid culture and DRTB center based on the drug sensitivity testing. So the treatment will be modified based on the sensitivity pattern. These are the three common situations which we used to see earlier. Nowadays, we don't see much, but still you need to keep that in mind. LIP, miliary TB and PCP, which mimic more or less similar in children, but how do you differentiate in children? So LIP is most of the time seen in older children by around 5 years and above. Miliary TB can be at any age. PCP is usually younger. Immunosuppression will be, it can be mild to advanced in LIP, mild to severe in miliary TB. It can be severe in PCP pneumonia. Clinical features in LIP will be chronic cough and no fever. Miliary TB, fever, cough and weight loss. PCP will be acute cough and tachypnea. X-ray finding in LIP will have persistent reticulonodular opacities, hilar lymph nodes. Miliary mottling in miliary TB, perihilar diffuse infiltrates, and response to treatment, no response to antibiotic and ATT. A good response to ART for LIP. Biliary TB will respond fantastically with the ATT, and cotrimoxazole and prednisolone will give a good response in PCP. The other sequelae like bronchiectasis you need to consider. Most common causes are recurrent inadequately treated bacterial pneumonias, tuberculosis, lip and HIV itself. So usually they present with chronic cough productive of cupeus purulent sputum, bad breath in the mouth, digital clubbing, coarse creptation. X-ray may be supportive. CT scan will definitely throw a lot of light in these children. So any child with chronic cough, look whether it's a persistent cough or a recurrent cough. If it is a persistent cough, look CBNAT and rule out tuberculosis. Otherwise, look at bronchiectasis and other lip and sputum negative TB. If this is a recurrent cough, give a bronchodilator. If there is a response, probably this is bronchial asthma or hyperactive airway disease. If there is no response to your bronchodilator, then it may be a recurrent pneumonia, foreign body, which is common in children, lip or aspiration pneumonias. So that the next common syndrome what we see in children is neurological syndrome. So neurological involvement in children is 3 times more common than in adult. That's because the brain is growing and immature in children, and it is very vulnerable for any insult in this age group. So primary involvement of CNS is seen in almost 50 to 90% of the perinatally acquired HIV infection. So the consequence can be catastrophic to a severe neurological encephalopathy, to a very mild learning disabilities or subtle neurological dysfunction in an older child. So neurological disease in the maybe the first manifestation of HIV infection in approximately 10 to 20% of the children. That means 1 in 5 or 1 in 10 children will have a neurological disease. The risk factors are, again, I said, route of infection, most commonly perinatal, severe immunosuppression, age of the child, especially if there is a manifestation within 2 years of life, or other comorbidity like prematurity, low birth weight, poor nutritional status. The spectrum of neurological manifestation can be anywhere between HIV-associated encephalopathy, that is hive, to HIV-associated neurocognitive disorders with severe neurocognitive impairment and dementia, to the stroke syndromes and opportunistic infection. So these are the various spectrum of neurological manifestations. So younger child may present to you with a global developmental delay, maybe a regression of milestone, acquired microcephaly, spastic paralysis, pyramidal symptoms, basal ganglia dysfunction, ataxia, seizures. Whereas older child may present with a slow, indolent progression or a regression of learned milestone, attention deficits, impaired cognitive functions, conversion, comprehension, and perceptions. So all HIV exposed infected children must undergo a routine developmental assessment. A detailed evaluation is needed whenever you see a SLHIV with developmental delay. or a poor scholastic performance in an older child or a behavioral issues, they need to be referred to a pediatrician and a psychologist for a appropriate management, counseling and support for the neurodevelopmental disorders need to be considered. Remember, the most potent preventive tool for a neurodevelopmental manifestation is early initiation of ERT. Early initiation of ERT will prevent a severe neurological syndromes in these children. So now opportunistic infections can be bacterial meningitis, tubercular, cryptococcal, CNS toxoplasmosis, CMV retinitis, encephalitis, and progressive multifocal leukoencephalopathy. So cryptococcal meningitis primarily occurs in an older child, 6 to 12 years of age, most of the time in an adolescent. Even in 6 to 12 years, if there is a close contact with a cryptomeningitis in adult. The occurrence is less common in younger child than in adult. Incidence is reduced again with the scale up of ERT. They usually present with an acute or subacute meningitis or encephalitis. Fever may be there, may not be there, but usually they present with a vague headache, malaise, more of like a vomiting. Neck stiffness and focal deficits are very rare. Diagnosis needs a high index of suspicion and presence of signs of raised ICT. So when you do a CSF analysis, cryptococcal, you will have most of the time a very normal looking CSF analysis, but the pressure, the initial opening pressure will be high there in them. And most of the time, as soon as you do a LP, they will feel relieved of headache. So, but you have to ask for India Inc. preparation, antigen testing, and culture. Tuberculosis, we all know they will have a lymphocytic pleocytosis in the CSF, and they will have high protein and a low to normal sugar. And sometimes you may get a MTB detected in the CSF either through your CBNAT or something like that. Whereas in acute bacterial meningitis, it is a neutrophilic pleocytosis and counts may be very high, may be purulent. Proteins are high and very low sugar. That is very important. Lumbar puncture should be done after ruling out CNS raised ICT by ruling out papilledema. If there is a scope for your neuroimaging, get a CT scan done and then do a lumbar puncture. Otherwise, there is a risk of herniation, maybe in an older child, not in a younger child. So in cryptococcal meningitis, the treatment is consist of 3 phases: induction, consolidation, and maintenance, or a prophylaxis phase. In the induction, there are various options we have. We can give amphotericin B with flucytosine, short course for 1 week, and then we can shift consolidation. Other regimen is 2 weeks of fluconazole and flucytosine, sometimes because amphotericin B may not be available, costly, not tolerable. So, or you can give 2 weeks of amphotericin B with fluconazole because flucytosine may not be available in some situations. So, depending on your availability and your experience, you can use these different regimen. There is no role of steroid in the management of cryptococcal meningitis. In the consolidation phase, usually you give fluconazole 6 to 12 milligram per kg body weight in children and adolescents. Usually the consolidation phase will be for 8 weeks. The maintenance of or a secondary prophylaxis is fluconazole 6 milligram is recommended till your ERT improves the CD4 count and immunosuppression. So in the CT scan, HIV encephalopathy, you can have cortical atrophy and bilateral basal ganglia calcification. Toxoplasmosis will have a single or a multiple ring enhancing lesion with a mass effect. Tuberculoma in the brain can have a single or ring enhancing lesion, and PML will have a single or multiple hypodense lesions in cortical white matter without contrast enhancement. Nowadays, with MRI available, the whole picture is changed with MRI, and the picture will be even more clearer there. The last syndrome is gastrointestinal opportunistic infections, where in this case, we have a 2-year-old newly diagnosed CLHAV with history of diarrhea from last 2 months. Remember, diarrhea of 2 months, failure to thrive, and loss of acquired milestones of 2 months. Child is just weighing 6 kgs. We expect a 2-year-old child to weigh around 10 to 12 kgs. This child is hardly 6 kgs. It's totally wasted, marasmic, not able to stand with support. Oral thrush, some dehydration, sunken eyes, generalized lymphadenopathy, hepatosplenomegaly. So there are various problems in this child. This child is having a persistent diarrhea, severe malnutrition, loss of acquired milestone, maybe CNS involvement. Child is having oral thrush. Child is having hepatosplenomegaly. So you name any of the things, everything is there. Stage 3 and stage 4 disease in this child. So how do you manage this child? Whenever a child comes to you with diarrhea, ask how long? Is there any blood? And look for danger signs: lethargic, unconscious, irritable, restless, sunken eyes, whether able to feed or drinks eagerly, and look at the skin pinch. If you pinch the skin, if it goes very slowly, more than 2 seconds or slowly, then you classify diarrhea. So any child lethargic, sunken eyes, not able to drink properly, skin pinch goes very slowly, severe dehydration, refer immediately. Our child is restless, irritable, sunken eyes is there, but drinks eagerly, drinking is there, thirsty, not lethargy, skin pinch goes back slowly, then it is some dehydration. You can manage with plan B correction. Okay. And if there is no signs of these dehydration, then there is no dehydration. You can give oral fluids and zinc. So if the diarrhea is for more than 14 days and dehydration is there, then it is called severe persistent diarrhea. And if there is a malnutrition, then it is a severe persistent malnourishing diarrhea. There is no dehydration, then there is a persistent diarrhea. If you see a visible blood in the stool, remember it has to be a visible blood in the stools. Many a times people, what they do is they get a stool examination, in that they will give RBCs. That is not dysentery. Dysentery means a visible blood in the stool. So it is called dysentery. So any child with a chronic diarrhea, that is diarrhea lasting for more than 14 days, is a major problem in HIV infected children. The organisms can be a protozoa, bacteria, viruses. Anything can be. So it needs a special staining and special investigative procedures. So the principles of management is supportive therapy with fluids and electrolytes, specific therapy wherever is required, and stage-wise evaluation if they don't respond. So hydration, zinc supplementation, nutritional management. ART specific therapy includes ART, code trimoxazole. Usually we give 10 milligram per kg body weight for in 2 divided doses for 10 days. Nitrous oxide for 3 to 5 days, 100 milligram. You can add albendazole based on what organisms you are getting it. So these are some of the specific therapies, and stage-wise evaluation. If they don't respond to that, you may have to go up to the colonoscopy or endoscopy to get biopsies and look at what is the cause for that. And nutritional management is very important. There is a stage-wise, step-wise nutritional management, diet A, diet B, diet C, and so that plan is so you can involve the nutritionist or a NRC program which is available in your setup. Can involve them, and you can use that. Some of the special staining required, like your modified Zn staining, is required for some of these rare organisms, Isospora belli, Cryptospora, and oocytes. So we all know there is a national immunization schedule. It's a very important tool in preventing many of the life-threatening diseases, not only in an immunocompetent children, even in HIV also. At birth, you need to give BCG, OPV, and hepatitis B. 6 weeks, you have to give OPV. Rotavirus is available now. IPV and pentavalent. Now even pneumococcal vaccine is available in many states. 10 weeks, 14 weeks, second and third doses. 9 months, you have to give measles vaccine. MR vaccine now, rubella is also given along with vitamin A supplementation. And in an epidemiology, in some of situation where the epidemic of JE is there, the JE vaccine is also available in the schedule. So second dose of MR vaccine is given at between 15 to 20, 18 months. At around 1.5 months of age, booster dose is given, and 5 to 6 years DPT second dose. 10 years and 16 years pregnant mother, TT1, TT2. There are other vaccines are also available in the private sector. Sometimes people may ask whether to give that. If it is available, if it is affordable, please advise that, like chickenpox vaccine, typhoid vaccines, hepatitis A vaccines. These children are vulnerable for these infections, which can be severe, which can be prolonged, which can be life-threatening, which can be associated with significant morbidity. So if they are available, if they are affordable, you can definitely advise them. And remember, when in the immunization schedule, this question will always come. What about the live vaccines? Some of the live vaccines are your rotavirus vaccine, OPV vaccines, BCG vaccines, MR vaccines. So BCG is usually given at birth. So there is no contraindication for BCG. You can always give BCG. But other vaccines, you need to be careful when you are giving at a later age group. You look at the immunosuppression. If the child is severely immunosuppressed, CD4 count is less than 15%. So you wait for ERT to kick in and immune reconstitution to happen. Once there is a immune reconstitution happening, your CD4 going up more than 15%, then you can give all these live vaccines. Otherwise, there can be a vaccine associated adverse event, which will be very difficult to manage also. So you have to be very careful, and you can also end up in some legal issues we don't know. So you have to be very careful when you are giving live vaccines in a child with HIV where your immune suppression is very severe. So the key messages are ART and age are the main determinant of OI profile or OI spectrum, what we are going to see in our clinical practice. Whatever said and done, tuberculosis is still probably will be the most common opportunistic infection among Indian CLHAV. There are diagnostic challenges, and these diagnostic challenges are the major hurdle for an effective management of opportunistic infection in CLHAV. These challenges are bigger than what we see in adult. So the management need a specialized skill and care. You may have to involve more specialists, more number of departments here, like pediatrics, psychologist, your neurologist if available, orthopedician if there is septic arthritis, skin specialist, definitely HIV physicians. So multi-speciality care is what is required here. Co-trimexal prophylaxis, IGICH prophylaxis, and immunization, these are very important component of prevention. Always keep your pediatrician on toes, keep them in loop, keep them in good humor so that whenever you need them, you can tap them, and you can save these children from getting into a severe illness, and even you can prevent mortality. So always refer to pediatrician if there are danger signs. Thank you very much. Any questions, I am happy to answer.
Thank you so much, sir.
This is treatment guidelines for HIV app. I think Shweta will
Yes, sir.
go through this.
Yes,
She
sir.
will lead you
So
through this.
if we can keep this slide for now.
Yeah.
Any questions from the participants? Thank you so much, sir, for the wonderful session.
Yeah.
Any questions from the participants? You can put them in the chat box, or you can even unmute now. Mic access has been given to all.
Good afternoon, sir.
Good afternoon.
Sir, I am Senior Medical Officer from ART Center, Bhubaneswar, Odisha.
Okay.
Sir, my question I have put in the chat box, but I want to directly talk to you.
Please go ahead.
That sometimes so happens, some deserted newborns are recovered by some child helplines and child agencies.
Yeah.
Whose parents' whereabouts are not known at all.
Okay.
If he is seriously ill,
yeah,
sometimes they suspect that he might be, we also suspect he might be HIV exposed.
Okay.
And how to approach those cases?
So your question is beyond the scope of this discussion. Today we are discussing opportunistic infection.
Of course.
What you are asking is
because we are pediatrician and
no. Okay, I will answer that. Your question is related to the HIV management of HIV exposed infants. So see here,
where parents status is not known.
I know. Yeah. So the quick thing what you can do is, you can do a rapid antibody test in the child.
Okay.
If rapid antibody test is positive,
Right.
then that will say this child is exposed to HIV. It
Okay.
will not confirm the diagnosis.
Yes, of
It
course.
will say that the parents are HIV positive. This child
Okay.
may be infected, may not be infected also.
Okay.
Correct? Yeah.
Okay.
So you can do a quick rapid antibody test, even though the guidelines say you do rapid antibody test only after 6 months, but still we don't know the parental status. We can
Right.
still do a rapid antibody test, do all 3 tests, not one test, all 3 tests. If all 3 are positive, then you can assume that this child is HIV exposed. You can do a virological test, that is TNA PCR. You can
Okay.
treat this child as an HIV exposed child.
Okay.
Okay. If rapid antibody test comes as negative,
Okay.
you are more or less assured that the parents are negative.
Okay.
More or less. I'm not saying 100%.
Okay. Okay.
So whatever the illness the child is having may be something different, not
Yes,
related to
can be.
HIV. Still, it can be HIV. I'm not saying that, but still, you are more or less excluding HIV exposure in that baby.
Right.
Okay. So a simple strategy could be you do a rapid antibody test.
Sir, you told that TNA also should be done.
Which one?
TNA test.
If rapid antibody test is positive,
Right.
young infant less than 18 months.
No, if the total newborn, suppose say for 7 days expected 7 days of age or something like that.
Yeah, then you
Should
do
we
a
go for
rapid antibody
TNA?
test. Do a rapid antibody test in that child. If that is positive, then you do a TNA test at 6 weeks. Well, you follow the protocol.
At 6 weeks or earlier we can do also.
No, you can't do earlier. You have to do it after 6 weeks.
Okay.
Yeah. Remember, it is an abandoned child. This child is vulnerable to all sort of things. Correct?
Okay.
So if there are any illness which is mimicking like a HIV, it can be due to non-HIV related things also because of the vulnerability.
Yes, it can be.
Yeah. So remember that. So just to exclude exposure here, you can do a rapid antibody test. If child is asymptomatic, is fine. You can wait for up to 6 weeks and then you can do rapid antibody test later also.
Okay.
Yeah.
Okay. Thank you, sir. Thank you so much.
Yeah.
So we have a question in the chat box. Up to
Yeah.
what duration can we wait for ART initiation in a CLHIV with an OI?
No, there is no general statement for that. See, ideally, the situation is you have to treat OI. After complete treatment of active OI, you have to start the ART. Now, the question is there are some situations where you can't wait for the completion of treatment. For example, tuberculosis. The completion of treatment will require 6 months of time. You can't wait till 6 months to start ART. In that situation, we say you stabilize the OI. So we expect by around 2 weeks of ATT, your tuberculosis will be stabilized. So you can start ART after 2 weeks of anti-tubercular treatment. Similarly, cryptococcal meningitis. In the cryptococcal meningitis, I said there are 3 phases. The first phase is intense phase, which will last to 2 weeks. And then there will be a consolidation phase, which will go for 8 weeks. You can't wait for 10 weeks to start ART. So you can wait till the stabilization, which we expect in the induction phase. After induction phase, if there is a stabilized child is stabilized, we can start after that. For example, pneumonia, acute bacterial pneumonia. Here you can complete the treatment within 7 to 10 days. So after 7 to 10 days of completion of therapy, if the child is stable, you can start ART. So you have to individualize your ART initiation timing based on what we are dealing with. If you have enough time to completely treat the treatment, completely treat the active infection, you do that and start ART. If you don't have that option, you stabilize and then you start. This is a generic guidelines I'm discussing now. Any other question? Can
Yes,
I
sir.
open the chat box?
Yes, sir, you can. I'll share this slide. You can stop sharing.
Yeah, okay. Yeah.
Yeah, there's one more question, sir. What is the ideal time to administer the live vaccines to CLHIV in terms of plasma viral load and CD4?
Usually live vaccines, we say CD4 percentage of more than 50%, 15%. Remember, your viral load has no direct consequence on the vaccine efficacy or a vaccine adverse effect. What is having the direct consequences? Your immune system. The immune system is reflected by your CD4 count. If your CD4 count is good, so we expect anything more than 15% is good CD4, is reasonably good immune system to respond to your vaccination. So for vaccination, please consider CD4 count. If any CD4 count of more than 15% in any age group, so you can have a reasonably good response to your vaccines, and you can more or less be assured that adverse event may not happen. So how to differentiate between clinical presentation of MAC pneumonia and PCP pneumonia? In fact, for MAC pneumonia in children, any different guidelines? The problem here is both of them, there is no the gold standard for the diagnosis most of the time is not available in most of the situation, even in tertiary care centers. So MAC pneumonia, usually you see in children with very severe immunosuppression. Usually your CD4 count is less than 15%, or absolute CD4 count is less than 100 or even 50. Whereas PCP will have can have in an older age group. MAC pneumonia will also have other clinical manifestation like anemia, chronic diarrheas, other manifestation. And most of the time, therapeutic trial, PCP will have a very good response with your Septron, whereas MAC will not respond to that. And the MAC will respond only to your ART. So ideally, in this situation, if there is a pneumonia, you start with the PCP pneumonia treatment, as well as cover with when you don't have a specific diagnosis, also cover for bacterial pneumonias. And I would even try to rule out tuberculosis. Once you do that and wait for the stabilization of the child for 8 to 10 days, your PCP pneumonia would stabilize by then, if there are no other features. There are no other features. If child is stabilizing, then you can safely call this as a PCP pneumonia. If anyhow you are going to start ART for these children, if there is a MAC pneumonia, that will respond to your ART. But you should always consider iris in this type of children, especially when your CD4 count is very low.
So
any guidelines on rabies vaccine for children bitten by street dogs? There is no separate guidelines in HIV. You can use the same guidelines, whatever is available for the regular thing, because your rabies vaccine is not a live vaccine. In case of TB, viral load test when done. We don't do viral load testing for TB. We do viral load testing for HIV. So HIV guidelines says viral load testing after 6 months, 1 year, and whatever the guidelines says, you can follow the same guidelines.
Thank you, sir. Any questions from the participants? Please feel free to unmute.
Sir, excuse me, sir. Rabies is a live vaccine, sir. That is why I asked that, sir.
Usually we give component vaccine. Huh?
It is live vaccine, I think. Rabies.
It's live vaccine? Sorry.
Yes, I think so.
Okay. There is no guidelines. I will have to check and come back to you in HIV.
Okay.
So only thing we are worried is yeah, it's a Viro Rab vaccine. It's a live vaccine.
Recently, we had a child, but of course, I told them to see if the dog was all right after 10 days. We don't.
No. We can't wait for that. I will check. And come back to you. But you can't wait for that. You have to look at the CD4. If CD4 is good, you can give the live vaccine also.
More than 350.
You can give.
Or
You can
percentage?
give.
Percentage is more important or absolute count?
It depends on the age of the child. If the age is more than 5 years,
6 years, I think, 6 years old child.
you can give safely.
Okay. Thank you, sir.
You can give safely.
Okay.
Let me check. Yeah. Any other questions?
So there are no questions in the chat box now. We'll just wait for another 2 minutes until we run the feedback poll. Is that okay, sir?
Yeah, please.
Yeah. Kiran sir, can we have the feedback poll? Yeah. Thank you. The feedback poll is now visible on your screen. The participants are requested to please attempt all the questions. There are 5 questions in all. You can scroll through the screen and answer the question. Just click on the answer of your choice. Let's make this quick. We have already crossed the 3 p.m. timeline.
So there is also killed vaccine available. You can try the killed vaccine and the rabies.
In a government hospital setting, sir, that is the issue. Privately, probably it may be a different issue. In a government setting is the issue here.
So is it available in the government setting? Because
No,
in our setup,
only the normal vaccine is available. That is all.
Yeah. So in our setup, even in the government hospital vaccines, I don't think it's available.
Requesting all participants to please attempt the feedback poll.
Okay.
Thank you, sir.
Thank you.
Any more questions? Participants can unmute or they can put their questions in the chat box. We'll wait for another 2 minutes for the feedback poll. You can scroll through the questions and click on the answer of your choice. Thank you so much, sir, for facilitating this important session.
Yeah.
Thank you to all the participants for patient listening. Kiran sir, we can end the poll now. Thank you to participants for attempting the feedback poll. We'll conclude the session now. Thank you.
So just
Yes,
a minute.
sir.
Rabies is an inactivated vaccine. So I think you can give it safely, not a problem. Thank you.
Thank you, sir.